Let's hear from our first speaker, who is Dr. Hannah Dunbar. She is a specialist low vision optometrist at Moorfields Eye Hospital, and she's going to talk to us about the benefits of a low vision assessment for children and adults with aniridia.
Thank you, James. It's really great to be here. So as James says, I'm going to speak about the benefits of a low vision assessment, and we thought it would be good to separate that into children and adults with an emphasis on aniridia. So to begin with, it's just worth revising over what the visual function impact of aniridia is, because these are the functional impacts that we will talk about in the low vision assessment itself. So as you guys will know a lot more than I, in aniridia, you'll have a very severe light sensitivity. So I'm sure today is a very, very challenging day here in the UK. There'll be a reduced amount of visual acuity or detail, and that's going to be variable depending on the light level. And also people can have nystagmus, which is an involuntary eye movement. And this can be worse when you're stressed or when you're tired. And so during those times, you would have even more difficulty focusing. But on top of aniridia itself, there are some other associations, other eye disorders that can occur that can also impact on vision. And it's important to consider the impact of these also. So this could be cataract, where the lens inside the eye gets cloudy, or glaucoma, where there's increased pressure in the eye, which can affect the optic nerve, or ocular surface disorders, where changes in the front of the eye make it harder for the light to get through. Now, luckily, there are treatments available for all of these associations. So it is really important to still have your regular eye clinic reviews with your eye doctor. But within a low vision assessment, we're not monitoring these conditions per se, but we're thinking about the impact that they might have on your vision in a kind of day-to-day sense. So in a low vision clinic, you'll typically be seen by a low vision optometrist, and we call the assessment a low vision assessment, or LVA. And the basic steps, although it will vary because it tends to be quite individualized to the person, but the basic steps would include a decent conversation at the beginning that we call the history and symptoms. But this is really a chance for you to talk about the functional impact of your eye condition, and also a chance for the optometrist to be thinking about ways to support that. We'll then assess vision, and we'll determine whether glasses or any magnification needs are there. And then we may talk a bit about technology, and we'll also signpost to other areas of support. And this will, as I say, vary person to person, condition to condition, and also between children and adults. So we're going to just take it for both individually. So thinking about the case of children, first of all, prior to a child attending their first low vision assessment, I would expect that they should already be having roughly 6 monthly glasses and vision checks in the eye clinic to make sure that their vision development is being optimized. And they'll probably have already been prescribed tinted glasses. And depending on the level of vision, their consultant will have suggested registration as sight impaired or severely sight impaired, and also a referral to a qualified teacher for visual impairment. Don't worry if you don't know too much about that term, I'm going to talk about it later. But when the child is approaching their 4th birthday, this is a really good time to try and schedule in their first LVA, or low vision assessment. And there's a number of reasons for this timing. First, it's a good age to start to interact with some of the vision tests that we do. And also it's a chance to think about the requirements for a particular child as they enter education. Now, when a child comes to the low vision clinic, if they haven't had these prior steps already, we will think about doing these referrals and making sure the glasses and vision is optimized. So when we have a child in our low vision clinic and we have that first conversation, we'll be asking the child about their vision, also the parents, and maybe also if the teachers have reported any change in vision or any concerns. We'll want to know about their history of glasses wear and whether they're wearing them full time, as sometimes glasses are prescribed to be worn full time so that vision development can be promoted. And we'll want to understand what support is available or provided currently, and whether there are any gaps in that support so that we can try to fill those or point people in the right direction to get the appropriate support. Now, I mentioned there this qualified teacher for visual impairment. In these conversations, a lot of acronyms come up, and I thought I'd just go through what they are now. So we'll talk about a SENCO. This is a special educational needs coordinator. That's a teacher who would usually be based at a school. They don't have specific experience in visual impairment per se. They're there to coordinate the needs for any child in a school who has special educational needs. So this could be vision, but it could also be learning difficulties, autism, physical disabilities. It's really a broad subject area. But then we also have qualified teachers for visual impairments, or QTVIs. Sometimes we also call them VI teachers. These are teachers who have done postgraduate qualifications in education as it pertains to someone with a visual impairment. Typically, they're employed by the local authority, but they will have a catchment of schools that they'll visit, and they'll visit children there who have a visual impairment. And they will assess a child's vision in school, functionally in the classroom. They'll make recommendations for the school, they'll talk to the teachers, and they'll also coordinate and correspond with families about the support that's being provided. Now, schools do have a legal responsibility to make reasonable adaptations to the curriculum to make sure that a child with any special educational needs can access their curriculum. But where additional support is needed outside that which you might call reasonable, then you can apply for an educational healthcare plan, or an EHCP. And this would sort of ring fence funding for the support needed, things like having specialist equipment or a teaching assistant, for example. It can be hard to get EHCPs. They tend to be reserved for children really in the most need, with complex needs, with vision that is likely to deteriorate, for example. And then for older children, when they're approaching university age, they can apply to something called DSA, or Disabled Student Alliance. And this is to have funding for similar types of support that will be necessary in university. So it's just useful to briefly go through what these acronyms are if they come up. So getting back to the low vision assessment, when a child comes in, we'll assess their distance vision, and we'll usually, depending on age, do this via pictures or letters, or matching letters and pictures against what's on the chart. We will do that either with a child's tinted glasses, or we can dim the lights to make sure that we're measuring their vision under the appropriate or optimized conditions. We'll also look at how their near vision is. And again, this can be done through symbols or letters, words, sentences, depending on the age of the child. And one of the important things here is to determine what's the optimal print size to promote learning for that child. So we often will think about in large print, but we want it large enough that it doesn't impede access and learning, but also not so big that it becomes cumbersome to work with. So it's really important to make that determination, and that size can change over the course of seeing a child depending on how their eyes develop or the complexity of the work that they need to do. And some children even will prefer to get closer to print even when it's larger. And in these cases, we might recommend something like a sloping desk so that the print can be held toward or closer to the eyes of the child without them having to adopt poor posture and causing problems later. Now, we'll also think about simple things like glasses. We want to know if you're wearing the glasses full time. And if you're unsure if your child should be wearing their glasses full time, really do ask, because when they're young, if we miss the opportunity to promote visual development, we can't get that back later. We'll sometimes suggest having separate pairs of glasses, so additional reading glasses with more magnification. And we'll definitely be recommending some magnifiers, optical magnifiers to children. Even right from the age of 4, we might start with simple magnifiers like a dome magnifier, which looks a bit like a crystal ball chopped in half with the flat surface resting on the page, and you look through the curved surface to get the magnification. We might use things like telescopes or binoculars for helping to see more in the distance on trips and outings, for example. And these optical magnifiers would then typically be loaned on the NHS in the UK. Now, we don't recommend these for school typically. It's much, much better if the child can have adapted learning materials, because if you're having to rely on, let's say, seeing the board through binoculars, there's a time lag there. It's hard to keep up and do that quickly. It can be much easier to fall out of the pace of the class. So we tend to recommend more adapted learning materials. Now, we'll talk a bit about technology as well in any of our low vision assessments, but it's important to know that technology has a really important place in education for children with visual impairment. And oftentimes we'll find that children are provided with either a laptop or a tablet, and this can be provided through the school, the QTVI, the Educational Healthcare Plan, or as I say, at university through DSA, the Disabled Student Alliance. And they have a number of really good features. So they can act as a relay system so that you can display what's on the board on a laptop or tablet screen closer to the child. School can send over worksheets and homework so that they can be viewed electronically, and then maximizing the view of those through accessibility features like zoom, increased contrast, or inverted colors. And also, if the device has a camera, you can use that as an electronic magnifier by taking a picture and then zooming the picture. And if a device has a keyboard, we can start to think about learning to touch type to take away the visual demand of typing. And that could be a really, really good skill for children with any type of visual impairment to learn. Now, if other more specialist equipment like screen readers, for instance, are required, then that too can be provided through EHCPs, as I mentioned. Examinations, like tests in school, this is a really important area that we will talk about. Obviously, exams are stressful for any child, but if you couple that with having a visual impairment, then we're going to have another layer of anxiety, potentially, a child worrying if they're able to see what they're being expected to answer in the examination. And typical arrangements that might be in place, although these will be very specific to the child, are large print modified papers, getting extra time to complete the examination, having someone to act as a reader or a scribe to write the answers, read the questions, the option to take the examination on a laptop or tablet and use the accessibility features to access the questions, to type your answers instead of writing so that you can much easier see them back, and also to have the option to take the examination in your own room or side room with the appropriate light level to support your best visual function. We'll also signpost to other areas of support. So again, based on the individual child's need, that could be referral to a mobility officer for mobility training. If any concerns around emotional well-being have come up, it might be referral to a pediatric counsellor. Of course, in the case of aniridia, we'll tell patients and recommend they contact the Aniridia Network and other charities too that do a lot of work around education, such as the Thomas Pocklington Trust, the RNIB and VICTA. Now, at the end of a low vision assessment, you should be provided as standard with a report of everything that's happened in that low vision assessment, but do ask because it doesn't always happen in my experience. And I think it's really good to be given that report after the appointment. Typically, when they're generated, they're sent to the GP and the parents. But if we have parental consent, we can also copy them to the QTVI and the SENCO, and they'll include a summary of the child's visual function, and that can be really helpful for the professionals who are looking after the child and supporting the child in education. Where we make recommendations around, let's say, print size and examination access, we can then record all of that. And a lot of families really appreciate having a letter from the hospital that supports the need for these types of recommendations. And also the documentation can be really useful if you're making an application for an educational healthcare plan, and it can be used to facilitate discussion between the school and the parents, for example. Now, in my experience of seeing many, many children with visual impairment in the low vision clinics, I would say that the children who get the best support are those whose parents are most engaged with all of these processes. Now, I appreciate that that can actually be quite a lot of hard work, but I just feel it's worth saying to be aware of that. So let's take a think now about adults instead. So again, we've got that history and symptoms conversation where you get a chance to report your subjective feelings around your vision. How are you experiencing your vision and the impact of your eye condition on lots of different domains of life? So home life, if you're a student at university, if you're at work, in leisure situations, when you're trying to access technology, how your well-being and mood is. But really, this is an opportunity for you to guide the conversation and tell us about the areas where your vision is impacting you in a practical way to see if we can help. And it's always good for you to guide that conversation a little bit too, if you can. So much like in the children's scenario, we're going to check the vision, we're going to check glasses, prescription, the refraction we call it. And we're going to do that at different distances. We'll always think about distance and near. They're the kind of standard measurements that are taken. But we also need to consider whether we need to measure at any other distance or what we call an intermediate distance, so somewhere between distance and near, because certain tasks will have distances that don't quite neatly match the distance or the near measurements. So things like looking at a computer, or if you are involved in music, looking at scores, if you do DIY, it literally could be anything. But one useful thing to do, if you know that you have a visual task at a particular distance and that distance is quite set, is to measure that distance. So that's the distance between your eye and where the detail is in the task. because that can really help the optometrist to work out whether a particular prescription or a magnifier could be useful at that required distance for that specific task. Now, if you're prescribed glasses or recommended glasses, it's always worth thinking about whether they're going to give you a significant improvement. And again, that comes down to your perception. Sometimes we can change a prescription by a large amount and a person may not feel that there's a difference there, or we can change it by what we might think is quite a small amount, but to that person, that small difference is really important. So you should really be guided and make sure you're shown the difference between any previous and new prescriptions to make sure you really feel that it's going to make a significant improvement to you at your level of function. We'll also think about whether particular magnifiers or what level of magnification can be useful to you. And when we do all of these assessments of vision, of refraction, of magnifiers, it's perfectly fine for you to request your preferred light conditions. Now, in some clinics, we might not have the option to have, say, a dimmer switch, but often we do. It might even be that you prefer that the room lights are off and the chart light is on, or the chart light is dimmed. So if you have a preferred or optimal light condition where we can assess your vision in a way that's more like the way you use your vision in real life, it's better for us to do that, but we won't always think of that offhand. So don't be afraid to point us in that direction. Now, with magnifiers, again, as for children, if magnifiers are recommended and you feel they're helpful, they're loaned on the NHS. And this could be simple things like higher powered reading glasses or handheld magnifiers, or magnifiers that stand on a page or task, or as I mentioned before, telescopes and binoculars. We also should talk about sunglasses and tints because of the light sensitivity. Oftentimes I'm asked, is there a specific tint? I should have a specific color, for instance, but really the answer is no. A lot of it will come down to personal preference. You just need to be comfortable. And it might be that you require a different tint level or color under different circumstances. So for instance, indoor light versus outside in a very bright sunny day like today. In the last year or so, we've had these new tinted over spectacles. So the glasses that you can wear over a prescription glasses called Cocoons. In the UK, they're supplied by Associated Optical, but they've become available in some of the NHS low vision clinics. And I mention them because I think it's really worth asking to see them when you next attend your appointment, if they have them available, because they have really excellent polarized tinted lenses. They are much, much nicer cosmetically than many of the other traditional over specs with side shields that we used before. And they're just made really well. And a lot of people have told me that they've really, really been helpful. So remember that name, Cocoons, because they cocoon your eyes. Do try and get the chance to see those if you can. So again, we'll signpost other support, and some of this will overlap with the support that we mentioned for children, like mobility training or counselling and the different charities we mentioned. We'll also want to make sure that you're aware of any of the benefits and subsidies that are out there, like applying for personal independence payment, or in London, a freedom pass or a bus pass in other parts of the country. And you can sometimes get a pass for your companion, a sighted companion, to go with you. And there's the option of subsidised rail fares through a disabled person's rail card. Now, when adults come to the low vision clinic and they're in employment or looking for employment, it's definitely worth having a conversation about access to work. Access to work is a government-run scheme that basically is there to support people with any disability or chronic health condition in the workplace. So much like schools, employers are legally required to make reasonable adaptations in the workplace. So for instance, if you want to use more magnification and you might need a larger screen at work, it's reasonable that your employer should provide that for you. But where there are additional support needs beyond what could be termed reasonable, then access to work is useful and you can apply to access to work for funding. And the types of things that might come up through access to work would be adaptations to premises or to equipment at work, whether a person needs specialist technology like screen readers or dedicated electronic magnifiers, whether a support worker is needed, or if you've got to travel a lot in your job, traveling support like taxis, or if you even have to travel to and from work, it might be that you want to travel at particular times of the day because of light conditions, and also even awareness training for colleagues. So it's really important that you know that access to work is there and available. And if you want to apply to it, you refer yourself. You don't need to wait on anyone else to make this referral for you. It is an online application through gov.uk, but they do have other accessible formats as well, but you can call them up and contact them. The RNIB and the Thomas Pocklington Trust have lots of great information on their websites about making applications and provide really good advocacy in helping people to fill out the application form that's needed, and also how to approach their workplace assessment. So what that is, you usually get an access to work advisor who will come and visit you in the workplace to look at your particular circumstances in work. Now, it's always better to apply to access to work earlier rather than later if you're starting a new job, because the level of funding that is applied is different depending on how long you've been in the job. I think it's if you're within 6 weeks of starting a job, access to work will cover all of the support. If it's after that, they'll cover 80% of the support and the employer funds the rest. There are also some stipulations around the size of the business as well. So businesses with more people have to make more contribution. But it's just really important to know that access to work is there, whether you're in employment or even if someone is not working. The reason they might not be working is because they're concerned about what support is available. So it's really, really important that this is discussed. So again, you would expect to get a summary of your findings, of the report, of the recommendations that have been made, but do ask for this because, as I say, it should be a standard. It doesn't always happen. It's sent to your GP, it's sent to you, and you can always discuss whether you want to share that report with your employer. This can be a tricky conversation because sometimes people don't want to disclose an eye condition or an issue. But I would say that if an employer does not know that you have a visual impairment, or for anyone if they have a disability, then they have a get out clause for giving you support, because if they don't know you need support, there's no legal obligation there. So it's always worth thinking about whether to disclose, and you can actually have a quite good conversation about this with your low vision optometrist who can give you some perspective on this as well. But the report also will provide the summary of your vision and your function and the support required. And if you do share it with your work, it reinforces their legal requirement to provide reasonable adaptations. And having a document from your low vision assessment can be useful for any of the assessments for access to work as well. So just to finish off, how do you get referred to a low vision clinic in the NHS? It's really the same whether you're a child or an adult. If you're under an eye department, your eye doctor should be able just to refer you to the local service. That might be within the same hospital or a different hospital, and in some parts of the country that might be in the community. But if they forget, because they're busy and they are looking after multiple facets of the eye condition, they do get focused on making sure that medically everything is okay. They won't mind if you remind them. Any chance you could refer me to the low vision clinic, I think it would be helpful. They really won't mind, do ask. If you aren't under an eye department, you can ask your GP to refer you to your local low vision service. In terms of following people up in our clinic, for children and adults in education or employment, we'd usually offer at least an annual follow-up to make sure that the recommendations for both of these domains are kept up to date. Otherwise, we say SOS, which basically just means tell your doctor when you want to be seen again in the low vision clinic. If someone doesn't have particular visual requirements, or their vision is very stable and their support is very good, they might think, oh, I don't need to come back for a while. But then they can request another appointment if there's a change in circumstances. And that's one of the times I think it's useful to request an earlier appointment. So even if your vision is the same, but you're about to change jobs or you're about to go to university, it's always good to request an appointment to coincide with that time. But similarly, if you've experienced any change, so decline in your vision, it's always worth requesting an earlier appointment as well. So a couple of little tips just to finish on how do you get the best from the LVA appointments for first year children. So do bring along any glasses and magnifiers that the child already has. Talk to your child in advance about their eye condition, their vision, any difficulties, so that you can help them to have that discussion with us, or you can discuss it on their behalf. Talk to the teachers before if they've noticed any issues. If you've got any reports from the visual impairment teachers or the SENCO, it's useful to bring those with you because that can really help us. And also, as I mentioned, ask for an LVA before any big changes. So if a child is about to start school, or they're going into a new school, or they're going to college, it's always worth trying to plan an LVA for a few months before, so we can think about that transition and how best to support a child at that time. For adults, is similar. Bring all your glasses, think about your difficulties in advance, what you want to talk to us about, and you can consider even writing a list. I know some patients be embarrassed about writing a list, but personally I find it helpful. Then I know I've checked off everything that you wanted to discuss. As I mentioned before, if you've got any very specific visual requirements, measure the distances that you need to view a task at, because that can be really helpful. And again, even if you can't, bring some samples with you of what you want to see, because that can be really helpful to us as well. But sometimes it's difficult to know if something you're recommending in a clinic room is really going to transfer over into real life. And then as for children, if there's any big change in circumstance, ask for an LVA before this. So as I said, if you're changing jobs, for instance. So to finish off, what I would consider some of the benefits of coming to the low vision clinic is that it's an opportunity to maximize your visual function and to discuss the functional impact of aniridia. And also you will have access to getting optical support provided by the NHS. Now, one thing I didn't mention, because we really don't have time, it's a huge topic, we also get a chance to talk through the benefits of accessible technology and make recommendations around that. Technology itself isn't provided by the NHS, but as I mentioned, you can get support for technology in education and employment. But there's so much that you can do with generic tech like smartphones, tablets, for instance. So we would go through that as well. And as I mentioned, we'll signpost and refer to other support within education, employment, and also social support, like the benefits and subsidies we mentioned. And I think it's really useful to get those written reports for education and employment. And one thing I would ask is, do remind your optometrist about your access needs for the report. No point in us sending your report in tiny print if you'd rather it be emailed. Similarly for children, if parents also have a visual impairment, it's absolutely fine to remind us. No one will take it to heart. It's not bad. It's helping the whole process for everybody. So last thing, because I didn't have much of a chance to talk about technology, I just wanted to mention a few websites that are really good. So the RNIB have a Technology for Life team. This is volunteers that you can ring up and they will support you with any access technology needs. Hadley, which is a school for the blind in the US, have a great website, hadley.edu/learn, where they've got lots of workshops on accessible technology and actually on lots of other areas that visual impairment impacts. AbilityNet have a great website called My Computer My Way, where you can plug in your operating system, your device, and it will generate lists of how to access all of the accessibility features for a given system or device. And also Guide Dogs in the UK have a Tech for All scheme where they've been providing free iPads and smartphones, Apple smartphones, to children between, I think, the ages of 3 and 8. It's been going for a little while. Occasionally they close it down for a period because they get so many requests. But if you didn't know about this and you haven't applied for it, do have a look at their website and see if they are accepting applications for that at the minute. And then lastly, Gene.vision is a really good clinical website where you can get layer descriptions of eye conditions. And if you need to explain an eye condition to another professional, for example, it could be a really good website to point them toward. And yes, that's me there. I hope I haven't ran over. I could talk about this all day, and I'm very happy to take any questions.
Thank you very, very much, Hannah, for that presentation. That was really, really helpful. There was a lot of information in there, and I'm sure people like me might like to look back at some of those. So we will make those slides available if that's okay with you, Hannah, for everyone to look at after.
No problem.
We have got a couple of questions in the chat, so I'll just rattle those off for you. Florian has asked whether there were things to know for babies that would differ from those of children.
So babies typically wouldn't come to the low vision clinic specifically, but all that information about what should happen prior to would be more important there. So I can answer from the point of view of the UK, but you definitely want to have a refraction. This is the glasses check. This will be done with dilated pupils, so they relax the focusing muscles in the eyes, and we look in with a light, and that will tell us how the eyes are developing from the point of view of a prescription. All little babies, normal little babies, tend to be long-sighted. So it's much more normal to be long-sighted at that very young age. Usually for little babies, we're thinking around like +3, +4. And then what we want to know is the prescription in line with the kind of age norms, or is it higher or lower, and do we need to prescribe for that distance? And also whether or not there are any differences between the two eyes, because that can mean that one eye might develop stronger than the other. They should also be seen by someone called an orthoptist, because they will look at the alignment of the eyes to make sure that the eyes, whether there's any squints that might limit the development of the vision as well. And if the vision is down, then definitely referring to the qualified teacher for visual impairment, the QTVI, because they will come out and support from birth right through to actually 25 if you're still in education. And they are a really good source of support for parents on how to promote visual development. And then, of course, being registered as sight impaired or severely sight impaired as appropriate by the ophthalmologist. The ophthalmologist might not know what level or if to refer straight away, because over the first years of life, vision will develop naturally as part of the maturation of the visual system. So we might not know very, very early what the limit of the vision is. And as we say, the more you can maximize that visual development at that early stage, the better. But it's still worth being referred for the qualified teacher of visual impairment. And if that hasn't been suggested, definitely tell your ophthalmologist that you want that done.
Thanks very much, Hannah. So the next question from Israel is whether we know anything about artificial irises with LCD screen contact lenses, and whether children have the opportunity or will have the opportunity of using them soon.
That's not really in my wheelhouse, to be honest with you, in the low vision clinic. I have seen a few patients with the artificial iris implants. It might be that people tend to come to me when they have problems more, but I've seen that they can cause some other further complications with, let's say, the pressure and the glaucoma. But I would direct that question more to an ophthalmologist, to be honest.
Okay, thank you. And then the final question from Teresa is around the cocoons and whether they're available in children's sizes and if they're available on the NHS. And also, Teresa's daughter gets 2 prescriptions, one for glasses and one for sunglasses. Would the cocoons replace one of those prescriptions?
They're not available, as far as I know, in children's sizes. I think there's like 5 different sizes, and small would be quite small for an adult, so it may double up as appropriate for a child. They don't have prescription in, they're over spectacles, so they're worn on top. So they wouldn't really replace, well, they could replace the need for a separate sunglass if you wore them on top of your clear glasses. We at Moorfields have had them, I think, for maybe the last year or so, but only in certain colors of tint, brown and gray. But if you just put cocoons into Google, you'll see that actually they're available in a huge number of tints and frame designs and such. And there's about 5 different colors that they recommend for low vision patients. Some other clinics I'm aware of have them in yellow as well, but yellow may not be that suitable in aniridia. It may not feel dark enough. But yeah, I'm actually not sure of how many of the other NHS low vision clinics have them. If your NHS low vision clinic doesn't have them, just say, look, Moorfields have them on the NHS. Any chance you can order them? Because a lot of times the company that supply them supply a lot of the magnifiers. So it may be likely that the hospitals are aware of them and could see if that's a possibility.
Okay, thank you.
Could I ask a question, please? I don't know how to put my hand up on my iPad.
Please go ahead, Paul. Please go ahead.
Hi, Hannah.
Hi, Paul.
First of all, I'd like to say that to anyone that's not had an LVA assessment, they're very valuable. I've been using them for probably 50 years now, and periodically go for a review. So just ready to back up what you've said and encourage people to go for them if they need to. But my question really is a little bit different, because I'm sort of from aniridia from birth, and I will be having another assessment because I've recently had a transplant again. But what I'm struggling with is my son, fortunately, has been spared my condition, 50-50 chance, and he was spared that. But now he's entering his last 2 years at school, and I'm battling a little bit to get the support to support him, and whether you have any ideas or recommendations for that, because I'm sort of battling with the school a little bit, because they're providing information to me and what they think I need, not what I actually need, because they want to do it just in a quick win, just chuck me what they think I need, and it's not what I do, because I can't access some of their portals and things like that. So it's a really important time for my son, because it's entering his last 2 years, and I'm doing his a disservice. Now, at the moment, I'm playing nice at the moment, but obviously I know the equality law. But time is running out, and things go on, and it's difficult because I don't want it to take another year, and he could fall behind.
So just so I'm clear, because I want to make sure I've got the right end of this. So is it that you're having difficulty to access the online portals that he's being made to use for education, though he can see them well, but it's hard for you to be able to see them and interact with them to support him?
That's exactly right, because everybody, parents could go on, log on independently. They can look at all the things, look at his Show My Homework and all the curriculum and everything like that. I'm at a disadvantage with that, and trying to extract information out of a 14-year-old is quite difficult.
What device do you use?
Well, they use like an in-school portal. Obviously, I use PC or Mac, but it's sometimes difficult to go onto those portals using the accessibility I've got.
So there's two parts to it. So one is, as you said, the law around this and how they would have a legal responsibility to be able to provide you better access. But in terms of making sure that you're maximizing your own access through your own PC or Mac, are you really familiar with all the accessibility features there, or do you feel there's room to explore those a little bit more? Because if you are, the RNIB Technology for Life team are really good, and they can actually remote access into your device if you give them permission, and not necessarily to read it out to you potentially, but to see if there's ways to adjust that for you. AbilityNet, again, and actually they'll be really good advocates in this because they're a charity really looking at access to technology for anyone with a disability. So I'm sure they would support you in any, not that you necessarily want to raise a grievance as such, but do you know what I mean? That they would help you on that side. The other thing, I guess, is just as I was saying about someone remoting in, it's probably a little bit left field, but things like Be My Eyes and Aira, if you've come across these apps for sighted assistance for tasks.
The Apple one's pretty good, but because mostly I'm a PC user, it's, sorry, I forgot the name of the app, but it's really good. You can point it at things and it'll read things and stuff. But I think it's the difficulty on their portal that makes things difficult. It's not very accessibility friendly. So normally when I'm comfortable with my own business, then obviously I can do the things I do, but it's difficult with something that's not really been adapted properly. So that's where I'm going with that. But the problem is I'm dealing with an academy as well, where I'm dealing with the executive head. There doesn't seem to be any HR or further grounds you can go with. And when they're using terms like, I don't want it to be burdensome for the teachers, that's like a red rag to me.
Yeah. If you go into a low vision clinic again soon, you could ask them to write, this is what's required, this is supported in law. And I guess it doesn't always work, but sometimes having those hospital letters can be helpful, which frustrates me because you're the best advocate for yourself here. Really, you know better than a low vision optometrist does. But sometimes having that backup is helpful.
Yeah, and at the moment I'm trying to keep with the school rather than backing against them, but obviously too heavy with the law is difficult.
Just one last thing, I'm sure people want to move on, but what about contacting the visual impairment service in your area that supports children with visual impairment and explain to them, because surely they know how to make that portal more accessible for children if they have visual impairment.
I think that's one of the sticking points because my son doesn't have the vision impairment.
No, but just tell them, this is the situation I'm in. Can you offer an advice on this? Because you still should be supported by your own adults service.
Yeah, because they're service providers. So
yeah.
Thank you. Thanks very much, Hannah and Paul. I'm afraid we do need to move on. Thank you very much, though, for that presentation. That was really, really helpful. And thank you again.
No problem. Thanks a lot.